Tips for diagnosing and managing dementia. You're on, Dr. Bosma.
Oh my goodness, what a way to start. Sorry. And I want to apologize to Sarah and Elle for nearly giving them a heart attack as I was stuck in traffic and just arrived at my office. But I am here technically on time and very happy to be here for our first web education presentation of this academic year. So thanks to everyone who's in the audience for joining. Just there we go. Um, Today's topic is, in case you forgot, 10 tips for diagnosis and management of dementia. And this is by no means meant to tell you everything about dementia, but is essentially a bit of a primer for some who may not know as much about it, and perhaps a good reminder for those who are much more familiar with it. And if you have seen this before, full disclosure, I have presented this at Web Education before, but I believe it's been a couple years. So hopefully it's not too fresh in anyone's memory. I have no conflicts of interest to declare. Our objectives for today, during the session, we will briefly review pathophysiology and etiology of dementia. We'll review a basic approach to diagnosis and management of dementia, and consider preventative measures for dementia as well, which of course we also call major neurocognitive disorder. So I guess tip number one, what is dementia? And I realize this is probably very obvious for many of you, but once again, for those who don't have a lot of background in this, this is just meant to be a bit of a primer. So dementia, or as it's known as major neurocognitive disorder in the DSM-5, is multiple things, but first and foremost, it's a loss of cognitive abilities. And the DSM-5, which provides our diagnostic criteria, state that there has to be a loss of one or more abilities in these cognitive domains. Probably the one everybody is most familiar with and thinks about most when it comes to dementia is learning and memory. And that's often the first thing that either the person with dementia, but more often their caregivers and loved ones will notice, is that their memory is not as sharp. And it's usually a loss of short-term memory. People usually retain their longer-term memories for much longer into their illness. But there can also be a change in someone's language abilities, whether that's the ability to find the right words or understand the words that are being spoken to them. There can be a loss of executive function. Executive function is essentially your ability to juggle multiple things at once, and it helps you essentially manage multi-step tasks. So it's really about planning, organizing, and carrying out complex things. There can also be a change in complex attention, and that's really a person's ability to sustain attention on multiple things at the same time. There can be a reduction in perceptual motor abilities, and that's essentially someone's ability to use their motor skills and navigate their environment. And there can also be a decline in social cognition, and that's really about recognizing what's happening in the social environment, sort of reading the room. So, like I said, loss of cognitive abilities in one or more of those domains. And ultimately, that results in the person who has dementia having problems with thinking, remembering, and reasoning. So being able to problem solve and find the best, most logical way forward. Pardon me. Dementia also requires a loss of functional abilities, and we classify function into two categories. One is ADLs, that's instrumental activities of daily living, and those are the more complex tasks that people carry out that require a lot of executive function. That would be like doing your banking, driving a car, buying groceries and planning a meal, remembering to take your medications, that type of thing. And then ADLs are activities of daily living, which some people call BADLs, or the basic activities of daily living. That's really managing your personal care, like dressing, grooming, bathing, eating, toileting, ambulating. And what we usually see is a person with dementia gradually loses their IADLs first, retains their ADLs until later in the illness when even their ADLs become impacted as well. And so essentially, to have a diagnosis of dementia, or major neurocognitive disorder, you have to have both a decline in one or more cognitive abilities and a decline in your function that's related to loss of your cognitive abilities as well. And dementia is put into 3 stages. And so the mild stage or the early stage of dementia is when someone has impairment in their IADLs, those more complex tasks, but they still retain full independence for ADLs. Once somebody slips into the moderate or middle stage of dementia, they start to have impairment in ADLs. Often we see that when one of the first signs will be with dressing. For example, somebody will start to wear the same clothes far more often than they normally would, or they'll wear clothing that's a bit more dirty than they normally would, or they won't pay as good attention to their grooming and hygiene. And then when somebody enters the severe stage, that's when they're really not independent anymore for IADLs and ADLs. And they still may be able to do some things. They may be able to, with cueing, still brush their teeth, but essentially they can't do anything on their own without somebody providing a framework or guidance for them. And it's really important to remember that dementia is very common the older people get. And so at age 60, about 1% of the population has dementia. By the time a person hits 85, they have a 30% risk of having dementia, and over 90, about 50% of people will have dementia. So it really is a disorder of aging. The older you are, the more likely you are to develop it. So that's tip 1. Tip 2 is that all dementia is not the same. And what we often hear is people use the term Alzheimer's and dementia synonymously, not really recognizing that there are some subtle differences between the two. And so dementia is really an umbrella term. There are multiple different types of or different etiologies or causes of dementia. The most common is Alzheimer's, which is likely why those terms are often used synonymously. But there's also vascular dementia, mixed dementia, where there's more than one etiology or one cause of dementia happening. And then a little less common would be frontotemporal dementia and Lewy body dementia. But those are essentially the big 5. Whenever we see somebody with dementia, it's most often one of these etiologies. Alzheimer's, as I said, being by far the most common, it's estimated that more than 50% of cases are pure Alzheimer's. Just a little bit of information about each of the different types. As I said, Alzheimer's is the most common type of dementia, and the hallmark symptom is early memory loss. These are the people who their family will say, sort of from day one, when they started to change, the first thing that was noticed was that they were becoming more forgetful around short-term memory, being more repetitive, having a hard time taking in and keeping new information, asking the same question over and over again, that type of thing. Alzheimer's is progressive. Everybody has a slightly different rate of progression, some people faster than others, some people slower, but it is progressive. There is no cure, there is no ultimate way to stop it. And it's generally, out of the dementias, one of the more predictable, in that we can usually anticipate what sort of symptoms you'll see depending on what stage the person is in. Vascular, not quite as common, especially pure vascular disease. And vascular dementia is when a person's presentation is because they've had vascular changes in their brain, or essentially a stroke, whether that's one or more. And a person can get dementia by having one stroke that's large enough that it impacts their cognition and function enough such that they have the diagnosis almost immediately after. Sort of more classic would be a stepwise picture where a person has multiple strokes, and after each stroke, you can see there's been a stepwise decline in their cognitive and functional abilities. And also not uncommon is something called small vessel ischemic disease, SVID. And that's when a person more gradually, without those incremental declines noticed after each stroke, that's when a person gradually develops and progressively declines with regards to loss of function and cognition. And that's essentially when there are likely thousands and thousands of tiny microscopic strokes that affect the white matter in the brain. Vascular dementia is a little less predictable by course. Because people often do decline depending on when they've had their stroke, it's a bit harder to predict what the progression will be. I know I've had patients who've had a stroke or two, clearly have dementia, but then didn't have much further stroke activity for a period of time and really plateaued. Whereas I've had other patients who've just had one stroke after another and really sort of dement much more quickly. But it's not as predictable as Alzheimer's. That being said, if you have evidence of vascular change in your brain, your risk of developing Alzheimer's pathology and having the manifestation of the disease show increases. It's estimated that people who have significant vascular burden have about 20 times the risk of developing Alzheimer's pathology. Pardon me. Dementia with Lewy bodies, much less common, but very noticeable when it happens because it does present differently than Alzheimer's. In addition to loss of cognition and function, there's a triad of symptoms that if you have one, you may have Lewy body. If you have two of these, you probably have Lewy body. And that is when the person presents with Parkinsonism early on in the illness, sometimes even before the dementia presentation is clear. And they don't necessarily truly have Parkinson's disease, but they have symptoms that are Parkinson-like. They also tend to have prominent visual hallucinations that can be very vivid very early on in their illness. And although everyone with dementia has some fluctuation, everyone has good days and bad days, people with Lewy body dementia really have noticeable fluctuation where from minute to minute or even hour to hour, you can really see changes in their cognitive abilities, being alert and oriented 1 minute and sort of more confused, an hour later. There are multiple other suggestive and supportive features. There's too many of them to go through today, but those can certainly be researched online with ease. And just like Alzheimer's, dementia with Lewy bodies is a progressive illness, often more rapidly progressive than Alzheimer's. People with Lewy body dementia generally have a shorter lifespan than those with Alzheimer's. Frontotemporal dementia, also not nearly as common, but very noticeable when it takes place. It is typically an earlier onset dementia, so average age of onset for frontotemporal is 55 to 65, whereas the other types of dementia tend to be a little bit older. There are two variants. One is the behavioral variant, which is more common, and that's where the person has an early personality change. So the first thing that family and friends notice is the person is a bit different. Often they're disinhibited. They may say or do things that normally they wouldn't. It's like their filter disappears. They can also develop apathy where they become disinterested and unmotivated in the things that they usually like to do. And there's very early executive dysfunction. So from early on, these folks may not demonstrate short-term memory problems, but they have a very difficult time organizing and planning and have very noticeable executive dysfunction, which translates into functional decline early on. The other variant is the language variant, and there's two types. One is called semantic dementia. That's where one of the first symptoms is the person has difficulty understanding the meaning of words. And there's also progressive non-fluent aphasia, where one of the first symptoms is the person has difficulty actually producing and finding words. It's non-fluent, their speech is often very halting and much more difficult to produce. The other type we talked about is mixed, and mixed dementia can be a combination of any and all of the above, but the most common combination is a mix of Alzheimer's and vascular, which makes sense given that having vascular change increases your risk of Alzheimer's disease. There are some other less common types of dementia. One is Parkinson's disease. About 20 to 40% of people who have Parkinson's disease will go on to develop dementia. There's Huntington's disease, where once again, a significant percent of people as their illness progresses develop significant cognitive impairment in addition to their functional decline. You can also get dementia from alcohol, excess alcohol use, which with abstinence can sometimes be reversed. And then there's the far less common, but still possible reversible causes like somebody with severe unmanaged hypothyroidism or a severe B12 deficiency could present with dementia. In the end, however, it's important to remember that all dementia is convergent. While depending on your etiology, it can start looking a little different. In the end, most dementia looks the same, and in the severe stage, it's almost impossible to differentiate one type from another. Pardon me. And I can see that there's comments coming up in the chat, which I can't read, but we will certainly address them at the end of the presentation. Tip number 3, pathophysiology 101. So what's the underlying pathophysiology? What's happening in the cell level? And we won't spend too much time on this because it's not as clinically relevant, but still good to know. Dementia is essentially a syndrome of apoptosis or cell death. So when you have dementia, the cells in your brain are dying, and that is why you present with your illness. There are different reasons, though, in the different types of dementia as to why your neurons essentially die. In Alzheimer's disease, the pathophysiological finding is plaques and tangles. So there's extracellular beta amyloid plaques, and we're going to talk a little about that amyloid hypothesis when we go through treatment later on. And there's intracellular tau neurofibrillary tangles. So essentially there's inappropriate deposition of these proteins both outside of and inside the cells, and that's what causes them to die. And the genetic cause for this is mostly heterogeneous. There's a few genes that are clear smoking guns, but for most people, it's a combination of multiple genetic variants that causes them to have this change happen, and we don't fully understand it yet. With vascular disease, very clear cut, you've had vascular change or stroke activity in your brain. So on the left side, we have evidence of a clear stroke where the blacked out area is. That's where there's been brain death in that area because of lack of blood supply and oxygen. And then on the right, which is an MRI, we can see white matter change. And that's where in the white matter, the interior part of the brain, you can see all of the white areas, which essentially suggests that those patches have been affected by small vessel disease. Lewy body dementia, the main pathophysiological finding is literally Lewy bodies. You can see the little arrow pointing to that purple globe within the cell. And we find Lewy bodies in people who both have dementia with Lewy bodies and people who have Parkinson's disease. In Parkinson's disease, the Lewy bodies are limited to the striatonagral pathway, which is one of our motor centers, and damage to that area of the brain causes the Parkinson's symptoms. In dementia with Lewy bodies, the Lewy bodies are found distributed not just in your basal ganglia, but cortically as well, more widespread, hence the more broad cognitive and functional impairment. And a Lewy body itself is called an alpha-synuclein protein aggregate, so we call Lewy body disease an alpha-synucleinopathy. In frontotemporal dementia, essentially what you'll see on a scan of the brain is atrophy in your frontal and temporal lobes with relative sparing of other parts of the brain until much later in the illness. And the underlying pathophysiologic change here varies. For some people, it's a tauopathy with tau deposits that shouldn't be happening. For some people, it's a protein called TDP43. What we do know is frontotemporal dementia is much more genetically based than some of the other dementias in terms of up to 40% of cases of FTD are familial. So there's a clear passing down from one family member to another. There is also this, and this isn't that important, but you may hear about it at some point. There's a newer hypothesis that there's an underlying pathophysiological change called LATE, which is limbic predominant age-related TDP43 encephalopathy. And it's actually estimated now that people who have much later onset dementia, so sort of over 80 to 85, they may not actually have true Alzheimer's pathology, even though their presentation mimics Alzheimer's. It may be that it's not tau or amyloid, but it's TDP43 deposition. And it's estimated that this may actually be the cause in 15 to 20% of patients. It's the only way to find out is to do an autopsy, and we usually don't do that. So most of these patients would be considered to have Alzheimer's disease. In the end, though, what happens to the brain is atrophy later on in the disease in all parts of the brain because of this cell death. All right, on to number 4, investigations. So let's say we have someone present who has cognitive and functional impairment, and we need to do a workup. What do we do? Um, what's recommended to do a medical workup for someone who may have dementia? Um, Number one, we often do cognitive testing to try and, at the very least, get a measure of current cognitive abilities and get a baseline so that you have something to compare to as the person progresses. Or you probably all likely heard of the MMSE, the Mini Mental State Examination, um, and that tests a variety of cognitive domains, except it does not test executive function. Whereas the MoCA, the Montreal Cognitive Assessment, also very commonly used, which is better at picking up more subtle changes early on in the disorder, that does test for executive function, or that ability to um, juggle juggle ideas and tasks and plan and organize. If you're only going to do an MMSE, it's highly recommended that you ask the person to draw a clock in addition to the MMSE. A clock draw is a very good and quick assessment of executive function. If you think of a good mnemonic for remembering what executive function is SOAP. It's the ability to sequence, organize, abstract, and plan. And when you draw a clock, you do all of those things. You have to organize and plan by drawing a circle that's big enough. You have to make sure there's space for all the numbers. You sequence by putting the numbers in order, and you abstract by putting the hands on the clock. We usually ask patients to put the hands at 10 minutes past 11, and that is an abstract concept in that a 2 actually represents a 10. And so that's one thing you definitely should do if you suspect that there might be dementia, is do a quick in-office cognitive test. As well, you should do some basic blood work. Most of these wouldn't be a surprise, your CBC lights, liver renal function, glucose, and a urinalysis. But really important to check for thyroid function and check a B12 level, as dysregulation in either of those can cause cognitive impairment that is potentially reversible. It's often asked if we should order neuroimaging for patients. Neuroimaging is a limited resource. Granted, a CAT scan is much easier to get than an MRI. And it is generally recommended to get an MRI if you can. But from the Canadian Consensus on Dementia, the last conference, or the fifth consensus, these are the last recommendations that are available from that group about neuroimaging. And they recommend that anyone who's had onset of cognitive and functional change within the last 2 years should probably have imaging. Anybody who, if they have unexplained decline, whether it's pre-diagnosis or even during the diagnosis, could possibly require imaging. If there's been a head trauma, you need to do it to rule out some sort of intracranial bleed, which can cause cognitive and functional impairment, like a subdural hematoma. Anybody who has unexplained neurological symptoms, you need to take a look to see what's going on in their brain. If there's been a history of cancer, you need to look for METs. If there's a risk of brain bleed, you need to make sure that they haven't been stroking. Anyone with significant vascular risk factors, you want to see if there's been vascular change. And there is such a thing called normal pressure hydrocephalus, where people present with cognitive decline and urinary incontinence and ataxia. And you take a look to see how big the ventricles are if you suspect that as a diagnosis. I'm just going to make a quick message. Sarah, I see there's a lot coming up in the chat. If there's anything that's urgent for me to answer, please do interrupt.
It's okay, Mark. There was one question. The rest of it's technical. And I think you can answer the question at the end.
Okay, sounds good. The modality, as I mentioned, an MRI is preferable. That being said, the wait for an MRI is lengthy. So we still often order CT scans just because they're more easily accessible. Something that most of you will likely never order. I've only ordered one once in my career. It's been in this past year, but it was for somebody who their presentation was very complicated and confusing. And hopefully this technology will be more broadly available moving forward, is a PET scan, positron emission tomography. And that really looks at cell function. They attach a radio tracer or radioisotope to whatever it is that you want to see its distribution in the brain. So the most common is to do an FDG PET, where they attach a radioisotope to glucose and it measures metabolism. So I had a patient recently who just couldn't figure out what their underlying etiology was, and they went for a PET, and it showed broad hypometabolism across most of their brain, which really suggested Alzheimer's. So very helpful. We don't usually ask for an amyloid PET, which looks at amyloid deposition in the brain, because even healthy adults have amyloid deposition, so it's not diagnostic. But this may be a technology that we rely on more commonly as the years progress. Pardon me. On to number 5, genetic testing. This is something I think people are getting asked much more commonly now from people who have dementia diagnoses is, should I have genetic testing? Should I see whether or not I have a gene or a set of genes that have likely caused this and that I may pass on to others? So this is why it's asked is family members will often say, will I get dementia? Should my parent or whoever has the dementia, should they have the testing? Should I have it to see if I've gotten some of their genes? And now people are, having much broader access to this type of testing as well, for less cost. For Alzheimer's, it is complicated. There's more than 70 susceptibility genes. And so it's, as I was mentioning earlier, really a heterogeneous illness. There's all these genes. Many people have many copies. It's unclear yet what combination of these susceptibility genes is required to develop dementia, and the interplay that they have with all the environmental factors that we experience. So it's a lot to process. The one that is a bit more clear is ApoE4 is very clearly linked to increased risk, especially if you have 2 copies of it, not one. If you have 2 copies, your risk of developing Alzheimer's goes up by about 20 times. There are also some autosomal dominant forms. They involve the presenilin gene. They're very rare, and those are early onset dementia. So if somebody has an autosomal dominant form, they're much more likely to develop dementia in their 40s or 50s or 60s. There are some other dementias that can have autosomal dominant genetics at play. So frontotemporal dementia, certain types, if a parent has it, you have a 50% chance. And it's the same with Huntington's, where if you get the copy, you will get it. But our general recommendations right now are that if you have a really early onset dementia, it's probably worth it because there may be an autosomal dominant gene at play. A very strong family history, especially if there's early onset dementia in the family, maybe, because if you have one of these genes, it can be diagnostic and predictive, especially for people who are thinking about making reproductive decisions based on whether or not they have one of these genes. But our general recommendation at this point is don't do genetic testing because even having some of these susceptibility genes, even the ApoE4, it's not predictive. It doesn't mean you will get it. So they don't have much predictive value at this point. All right, on to number 6. We're halfway, if not a bit further. Current drug interventions. So that's the other question we always get asked is there medication? Is there a drug that I can take to help manage my disease? Pharmacologically, the most commonly prescribed medication is a cholinesterase inhibitor. These have now been available for quite some time, at least a couple decades. In fact, I think more than that. We're probably at 25 years, if not even more. And they used to be really expensive, not covered by pharmacare. That's all changed now that they've gone generic, and they're widely available and not particularly cost prohibitive. There's 3 types. They have a mild to moderate effect size in terms of efficacy, but they are definitely not a cure. And we really have to remember to tell patients this so that they don't have expectations that can't be met. The indications for cholinesterase inhibitors are Alzheimer's dementia, dementia with Lewy bodies, Parkinson's disease dementia, mixed dementia, especially if one of the types is Alzheimer's. And more controversial now, would be vascular. So there used to be, the evidence used to tell us don't use cholinesterase inhibitors for vascular dementia. They don't work. Newer evidence has said they might be effective, especially if it's a mixed vascular presentation. So it's probably worth using a cholinesterase inhibitor in somebody with vascular pathology. Um, that's how things are trending at this point. The types that don't respond, frontotemporal dementia does not respond to cholinesterase inhibitors, and neither does Huntington's disease. But the types listed here, you should definitely consider using one. The duration of treatment, so occasionally when we put someone on a cholinesterase inhibitor, there will be this sort of bounce in cognitive and functional ability. More often than not, though, what you're hoping for is that they'll plateau for a period of time, perhaps 6 to 12 months. So essentially, you're delaying their progression by that amount of time. And for some people, it's less time than that. For some people, it's more. It's really idiosyncratic. And you really have to wait a good 3 to 6 months to assess the benefit, just to see, are things still progressing or have they kind of stayed the same? It is really helpful to consider a few target symptoms to measure. So, often keeping track of short-term memory and perhaps 1 or 2 areas of function to measure to see if the person's retained their abilities or not is a helpful way of measuring if these medications are working. Discontinuation is a bit controversial. Some people think you should discontinue if the person's reached the severe stage where there's probably no benefits. Others now think it's best to just keep the cholinesterase inhibitor on board because there certainly are cases where the cholinesterase inhibitor was discontinued and there is a precipitous decline or emergence of challenging behaviors. Really important, though, to discontinue when there's side effects and they outweigh the benefits of treatment. There are some newer drugs, which this has really been in the news over the last couple of weeks. So aducanumab was approved in the States, never approved in Canada. Lecanemab just got approval, and that's really what everyone's talking about now when it comes to dementia management. These are essentially drugs that bind to and remove amyloid from the brain, as it's postulated that inappropriate deposition of extracellular amyloid is one of the underlying pathologies of Alzheimer's disease. They are complicated drugs, though, in that they're not easy to administer. So although we've had approval in Canada now for lecanemab, to get this treatment, it's an infusion every 2 weeks. It's an MRI every, I believe, 3 months in your first year of treatment to look for ARIA, amyloid-related imaging abnormalities. So essentially, up to, I think, 17 to 20% of people can have imaging abnormalities. They're thought to, I think, be microhemorrhages that are asymptomatic in most people, but you have to have routine MRIs to look to make sure that you're not having this side effect. You have to have genetic testing. People who have both ApoE4 alleles are much more likely to have this ARIA side effect. And essentially, having the resources to provide regular infusion and especially having MRI machines available to do MRIs on people who'd be treated with this, we don't have those resources at this time. So I suspect it's going to be several years before they come to market for the broader population, although one could see that private clinics may be able to offer these things sooner, but that really remains up in the air. So the other challenge is these drugs work best very early on in dementia, and it's very difficult to catch people at the moment when they're in the early mild stage. People often don't present until at least a couple of years into their illness. So like I said, a variety of challenges. We'll see what happens, but our sort of message to patients right now is not available, don't know when. We'll keep you updated. All right, moving on to number 7. You should expect BPSD, behavioral and psychological symptoms of dementia. The psychological symptoms tend to be depression, anxiety, irritability, apathy, psychosis, and emotional dysregulation. Depression, anxiety, irritability, apathy, much more common in the early stages of dementia. Psychosis, more common in the later stages. And then behaviorally, things like wandering, agitation, whether it's verbal or physical, aggression, whether it's verbal or physical. Some people hoard, some people can't sleep, some people have inappropriate sexual behaviors. Typically, things like more severe agitation and aggression don't happen until the moderate to severe stage. But you need to expect and anticipate that these symptoms will occur, as 97% of people with dementia will have some symptom of one of those that we've just listed. These symptoms have effects on people. If you have significant behavioral or psychological symptoms, they decrease your quality of life. They lead to more likelihood of caregiver burnout because they just make caregiving that much more complicated. They are more predictive, the more severe they are, of a quicker decline in the illness. They predict earlier long-term care admission. So they are a big deal that we have to keep an eye out for. And the approach is obviously identify them when they happen. Always consider the causes or potential underlying etiologies of behaviors in dementia. Sometimes they, pardon me, Sarah just brought me some water. Thank you, Sarah. Sometimes they happen just as the natural course of the illness. There's no other cause. They just appear because that is what is going to happen with that person. But a rapid change in behavior or mental status, you certainly have to wonder about an underlying delirium. You also have to consider an underlying psychiatric illness. So let's say somebody had pre-morbid histories of depression or anxiety or psychosis. If they're presenting with those symptoms in their dementia, you have to consider that they may have been there before and may need a slight different approach to treatment. You really have to consider unmet needs as well, especially as people progress in their dementia. They may not be able to tell you anymore what's bothering them. And things like hunger, thirst, constipation, pain, to name a few, those things may not be clear to you and can't be communicated by the person. So you have to consider that they may be possible. And the environment as well can certainly have a big impact and influence whether a person demonstrates these behaviors. And that can be because the environment could be understimulating, it could be overstimulating. A variety of things can be at play. So when we have a patient with BPSD, in terms of management, we always have to think about non-pharmacological intervention first. Meds do have side effects and can have an impact, both positive but sometimes negatively, on quality of life. So non-pharm always first. And that's when we look at managing the environment. If there's something in the environment that's triggering a behavior, we do what we can to fix it. If there's unmet needs like pain, thirst, hunger, constipation, we treat those. Really important to educate caregivers as well. If they don't have an understanding of what's happening, they may not know how to approach the person and manage these issues. And important to create a care plan, especially when a person's in a long-term care setting. All care members, all members of the team should be on the same page, and it can be very helpful to have a care plan that everyone follows to manage these behaviors. Pharmacological is second, and a talk on pharmacologic management of BPSD is an entirely separate talk, so we're not covering it in big detail today, but generally you'll see SSRIs and antipsychotics used, and if it's depression or anxiety or psychosis, we may target those with the medications that we typically use for those presentations. More milder agitation, whether it's physical or verbal, usually gets an SSRI. More severe agitation or severe psychosis or more severe verbal or physical aggression usually warrants an antipsychotic medication. And for more information about that, the Canadian Coalition of Seniors Mental Health, they recently updated their BPSD management guidelines. I think they updated them in 2024, and they give very clear direction about pharmacologic intervention, when and what to use. So that's a very helpful resource. Tip 8, do not forget about driving. And this is something a lot of us dread managing or addressing. One of the worst things that can happen to a person in dementia is for them to lose their license. Most people identify that as the change that really left them feeling like they'd lost their independence. But even though it's emotionally charged, it's really important. Um, Most older drivers, those who don't have dementia, are still safe to drive. But when dementia is diagnosed, you can certainly have deterioration in your driving skills. It's not if, it's when. Evidence shows collision is more common. Um, Driving may continue, but it does have to be assessed routinely so that you are able to sort of catch when the moment arrives when it's no longer safe for the person to drive. Um, it is, as mentioned, a difficult conversation, but one that cannot be avoided. Pardon me. And the assessment or the approach to considering whether someone can drive or not is it's multifactorial. So you do have to obviously assess the impact of dementia. How functionally impaired is this person? And we'll talk about some tips on how function can impact the ability to drive. Important to assess comorbidities as well. Um, Pardon me. If somebody has a lot of physical comorbidities, if they're really frail, that certainly is going to affect their driving ability. They may physically not have the response times or coordination available anymore. That cognitive assessment is really important. If somebody is scoring really poorly on a test, that's probably predictive. There's underlying issues. And you have to look at their driving history as well. If since the dementia diagnosis, they've been, slamming into other cars, getting into fender benders, that's going to help you as well. But really, it's all sort of areas of this information are going to be giving you some guidance. A general tip, if a person's ADLs are impaired, meaning if they're in the moderate stage of dementia, it's no driving. There's no question about that. The license has to be revoked. If somebody has 2 or more IADLs that are quite impaired, then it's likely they shouldn't be driving anymore. Granted, by the time we see most people with dementia, they have had impairment in 2 or more of their IADLs. So at the very least, at this point, you may have to send them for a driving assessment. And that's become a little bit more complicated lately, um, in that access to uh, elder driving assessment programs is limited. They're also often costly, and many of our patients can't afford them. If the person can't or won't go to a private driving assessment company, you can certainly fill out a medical form for Department of Motor Vehicles, send it in, and request that the person has a driving assessment. Essentially, they then have a regular driving test, just like a 17-year-old would. In all honesty, they usually fail, but you can certainly go that route as well. But the reality is, if you have enough concern about driving and don't think a test is required, you feel certain that they shouldn't be on the road, you can revoke their license, send a letter into DMV at that moment, tell them not to drive again. And we always tell people as well, once they've been told that, they're essentially not covered by their insurance company anymore. If the insurance company got wind they'd had their license revoked, they'd have no coverage. When you do take away a license, it is, this seems obvious, but important to provide some emotional support because it is really difficult. If you do deem a person as safe to drive, they should be reassessed frequently. We usually suggest every 6 months, unless there's been a more noticeable decline in between. And like we said, if it's really unclear if they should be driving, send them for a driving assessment. Then it is up to you to judge whether or not they can still drive or shouldn't drive while they're waiting for the assessment. Nova Scotia has the rule that there's no duty to report here. It's not a must report, it's a should report, but it's better to be cautious and conservative than not. But there are many other provinces in Canada where as soon as you have a diagnosis of dementia or certain other medical or psychiatric comorbidities, you lose your license then and there. An excellent driving resource is www.drivinganddementia.ca. This was developed by a geriatrician and his colleagues in Toronto. Really a wonderful resource, so I'd encourage you to use that for more guidance. All right, we're heading to the end here. Special populations. Thought it was really important to talk about dementia and schizophrenia. And I might throw bipolar disorder in there too, but schizophrenia is even more important to discuss. It's not that infrequent that our service gets asked to do a cognitive or dementia assessment on somebody who has a lengthy history of schizophrenia. Um, People who have schizophrenia, or perhaps a better term would be a severe and persistent mental illness like schizophrenia or bipolar disorder, they do tend to have baseline cognitive deficits because of their illness. At baseline, they may have some deficits in attention and working memory and executive function. And the evidence does show that if you have a diagnosis of schizophrenia or bipolar disorder, you do have a higher risk of developing dementia. But it's important to dispel the myth that everyone who has a severe and persistent mental illness has an inevitable decline. That's actually not true. The evidence shows that although there may be underlying baseline deficits that occurred and have been stable from early on in the illness, it's not inevitable. Not everyone with these illnesses has eventual progressive cognitive and functional decline. And so if you have somebody with a severe and persistent mental illness and you're worried that they may be developing a major neurocognitive disorder or dementia, really important to make sure you know what their baseline is. What's their baseline cognitive ability and baseline functional abilities? If they are actively psychiatrically unwell and their cognitive and functional abilities have declined, you can't assume it's because they have dementia. People who are actively psychotic, manic, or more severely depressed, that is going to impair their cognitive and functional abilities as well. So you need to treat the illness first before making that assessment about whether they have an underlying dementia. And also really important to ask, what's different now? So if there's been an acute change in cognition and function, then you really have to suspect there may be a recurrence of their psychiatric illness. But if they're psychiatrically at their baseline, not in an acute episode, and they're still having ongoing progressive cognitive and functional decline, meaning the decline is happening in the sort of absence of acute mental illness, then you might begin to suspect that the person does having an underlying dementia. And unfortunately, there's no magic wand to know. Often it's a case of time will tell. And that's what we will do then, is sort of intermittently check in on over time to see if the cognitive and functional abilities decline in the face of stable psychiatric status. Finally, this is number 10, and probably one of the most important things here is prevention. And this is a last, but definitely not least. It probably should be a first, and that we need to think about what can we do to prevent people from developing these neurocognitive disorders. There was a really seminal paper from 2020 in The Lancet that looked at dementia prevention, intervention, and care. And it identified that up to 40% of cases of dementia could be preventable if these risk factors were better managed. So it's not just genes. These are risk factors that are somewhat under our control. So the things that are really important to do to try and prevent dementia, number one is to keep your brain active. Learn new things, engage your brain in mentally stimulating activity, puzzles, Sudoku, word search, learning a new language, playing an instrument, keeping that brain going. That keeps the brain connections and in fact builds new ones that are protective of neurocognitive decline. Managing your blood pressure, also a really big deal. It's been shown that clearly managing blood pressure does prevent dementia onset. Hearing impairment, and this is a newer one, but it's now estimated that hearing impairment may in fact be the most important risk factor to be managed. People who have unmanaged hearing loss, they have much higher rates of dementia. So, people, we so hear like, I don't want a hearing aid. I don't have, it's not a big deal. It is a big deal. And I tell all my patients now when they're complaining about their hearing that they need to get that managed. Otherwise, they're at higher risk for dementia. And I think, has been effective. It's sort of lighting a fire under people to get that assessed and managed. Obviously, don't smoke. It's a vascular risk factor. It's a risk factor for dementia. Um, Weight management also important. So obesity is linked to higher rates of dementia. Unmanaged depression or psychiatric illness also increases risk of dementia. People who have late onset depression, for example, especially if it's untreated, have higher rates of dementia. And sometimes actually late onset depression is even a sort of early warning sign that this is about to happen. Sedentary lifestyle is a risk factor. So exercise is preventative. Getting off the couch, getting your cardiac exercise 2 or 3 times a week to get the heart rate up is really helpful. Even walking every day, any form of exercise is useful. Good management of diabetes, which is a risk factor. Making sure you're not socially isolated. So social connectivity is a preventative measure. Keeping your social connections, keeping socially active, really important. No surprise, uh, um, abstention from alcohol. I find this a bit controversial in that the newer guidelines are so restrictive. They're like a drink or two a week, which lots of people do not stick to. But we certainly can, with certainty, tell people heavy, regular, ongoing alcohol use is clearly a risk factor. And I'm sure we have all seen patients who develop dementia because of their heavy alcohol use. Try and protect your brain. Brain injury, traumatic brain injury is a risk factor. Pollution, I mean, this is a bit harder to manage. It's not like people are going to move to another city with lower pollution to prevent dementia. But interestingly, there now is evidence that people who live in geographical areas with higher rates of pollution have higher rates of dementia. And diet. So everyone talks about the Mediterranean diet. There is evidence that a good, healthy diet, especially with that Mediterranean focus, can reduce your odds as well. So that's the end of our talk. I hope those have been some helpful tips. We certainly have time for questions. I'm going to stop the share, and we have about 6 minutes.